not too much of material in this talk. It is much more lighter as compared to the, if you are going to compare this with a forearm, it's much more, easier to understand and much more easier in terms of the content. Okay. So if we look at the popliteal fossa, so popliteal fossa is basically a diamond-shaped space behind the knee joint. So it's just like a, it has a four-sided diamond-shaped space behind the knee joint. So the bony landmarks of the popliteal fossa include the popliteal surface of the femur, so that forms the floor. On that floor you have the popliteal pad of fat as well as the popliteus muscle. So the posterior or popliteal surface of the femur is basically forming the floor. If in terms of the superior boundaries, you have semitendinosus and semimembranosus on the medial side and biceps femoris on the lateral side. Lateral superior. And in terms of the inferior boundary of the popliteal fossa, you would find the medial and the lateral head of the gastrocnemius. These are basically forming the boundaries of the popliteal fossa. In terms of the roof, it is formed by the popliteal pad of fat, and there is skin. Yes, go ahead.
I'm sorry, but I think you missed.
Yeah, there is no biceps femoris, here. Superior lateral boundary is not written, which is biceps femoris.
Yeah,
so we have already said that. Okay. So, okay, then the contents of the popliteal fossa include popliteal pad of fat. There are several popliteal lymph nodes there. You have, mainly the popliteal fossa is important. Like the femoral triangle, it is a neurovascular bundle. So the neurovascular bundle of the leg is going to pass through the popliteal fossa and then enter into the leg. So you have mainly the popliteal artery, the popliteal vein, and the tibial nerve, which are the major contents of the popliteal fossa, besides the pad of fat and popliteal lymph nodes. So if you look at the superficial to deep, you would find the tibial nerve is the most superficial among them. Then you have the popliteal vein, and then you have the popliteal artery. So the popliteal artery is the deepest structure in the popliteal fossa. So nerve, veins, and artery. If you remember the orientation in the femoral triangle, the nerve was lying laterally. Then you have the artery, and then vein was lying most medially. So vein, artery, nerve was medial to lateral. Now it has turned like this. So you have the nerve, which is up. Then you have the vein, and then you have the artery. So superficial is the tibial nerve. Then you have the popliteal vein, and finally the deepest structure is the popliteal artery. On the side you have the common peroneal nerve, which is passing over the lateral boundary of the popliteal fossa, and you also have the small saphenous vein, which will pierce the roof of the popliteal fossa to enter into the popliteal vein. Now you can see that the popliteal artery is quite deep here in the popliteal fossa, and if you have posterior dislocation of the tibia, during the dislocation of the knee joint, you can damage the popliteal artery. And if the popliteal artery is going to be ruptured, the blood supply to the leg would be compromised, because it is the popliteal artery which goes down at the lower border of the popliteus muscle. It is going to divide into anterior tibial and posterior tibial artery. Anterior tibial is going to supply the anterior aspect of the leg. The posterior tibial is going to supply the posterior aspect of the leg and the foot. So if there is a posterior dislocation where the tibia moves back, there would be because popliteal artery is lying just on the back, so it can the condyles of the tibia can rupture the popliteal artery, and as a result there could be a hematoma in the popliteal fossa, and there would be loss of loss of blood supply to the leg and the foot region.
Because the popliteal artery supports the leg with the foot.
It supplies the leg and the foot. Okay. So what you are seeing here in this diagram, this is the popliteal fossa again. You can see the superior boundaries, and these are the inferior boundaries. You can make out that this is the biceps femoris. Here the semimembranosus and semitendinosus are located, and these are the two heads of gastrocnemius. So this diamond-shaped space which you are seeing is the popliteal fossa. If you remove the popliteal pad of fat, then you can see the three major contents: the tibial nerve, the tibial vein, and the artery, the popliteal artery. So tibial nerve, popliteal vein, and popliteal artery are the three major contents. On the lateral aspect, you can see the common peroneal nerve. Can you make out that? And then here you can see the small saphenous piercing the roof of the popliteal fossa to enter into the popliteal veins. So these are the contents and these are the structures of the popliteal fossa. The other thing which can happen here is that you can have a cyst here, which is called in the popliteal fossa, if you have a cyst which is called the Baker's cyst, and it can happen because of the trauma or the swelling from the knee joint can be going there and results in the formation of a cyst, which is the Baker's cyst. The third thing which can happen is an aneurysm or dilatation of the popliteal artery. That can also happen. So you can have aneurysm of the popliteal artery, you can have Baker's cyst. So you need to, if there is a swelling at the back, you need to differentiate if it is an popliteal artery aneurysm or it's a swelling which contains which is because of the trauma to the knee joint.
What is the meaning of the word aneurysm?
Aneurysm is a dilatation of the artery. So there could be a dilatation of the artery, that is called the aneurysm. So there could be a popliteal aneurysm here because of the popliteal artery dilatation. Okay. So the bones of the leg, we have tibia, which is the most common of the long bones to be fractured. It has a relatively poor blood supply. Its anterior medial surface, which you see here, this anterior medial surface is called the shin bone. It's all subcutaneous, so it has no muscular attachment. So anterior medial surface of the tibia is subcutaneous. It is just under the skin. You can feel your anterior medial surface of the tibia. It's called the shin bone. There is a soleal line on the posterior surface of the tibia which gives attachment to a muscle which is soleus. We would be talking about that. Fibula, on the other hand, is the lateral bone in the leg, and it gives two intramuscular septums which are attached from anterior and posterior borders of the fibula, giving the three compartments of the leg. And it has a lateral malleolus which is important in the ankle stability. We will talk about that too. So let's look at some of the bony landmarks of the tibia and fibula. So this is the anterior view and this is the posterior view, and you can see this is the femur, this is the tibia, and the lateral bone which you see here is the fibula. This is the neck. Patella is a sesamoid bone which is present in the tendon of the quadriceps. So technically you would take it as a part of the thigh rather than the leg. Okay. So what you're seeing here is this lateral bone, which is the fibula. The medial bone is the tibia. These are the tibial condyles. So this is the medial condyle of the tibia, and this is the lateral condyle of the tibia. And in between the two condyles, the medial and the lateral condyle, you can see this eminence. This is called the intercondylar eminence. These are the articular facets, and these articular facets are going to articulate the condyles of the tibia with the condyles of the femur. And then you can see this area, which is the medial surface of the tibia. You can see the Gerardi's tubercle here on the anterior aspect. You can see the tibial tuberosity. This tibial tuberosity gives insertion to the ligament of Patani. Posteriorly, you can see the soleal line, and the soleal line gives attachment to the soleus muscle. Anteriorly, you can see the anterior border of the tibia here, which separates the anterior medial surface of the tibia, which is this one, which is subcutaneous, from the anterior lateral surface of the tibia. So this is the anterior lateral surface, this is the anterior medial surface. In between them, there is the anterior border of the tibia. Medial surface, as I have said before, it's subcutaneous. Anterior lateral surface will form the anterior, the muscles which are going to come from in the anterior compartment of the leg. Then you have the head of the fibula here, the neck of the fibula. The important thing about the neck of the fibula here is that it is associated with the common peroneal nerve. So common peroneal nerve passes around the neck of the fibula, and then it enters into the peroneus longus muscle, where it divides into superficial and deep peroneal nerve. But the common peroneal nerve is basically associated with the neck of the fibula. And if there is a fracture of the neck of fibula, common peroneal nerve is the one which gets damaged. And because it is giving the deep and the superficial peroneal and deep peroneal nerve supplies all the anterior compartment muscles, which dorsiflex the ankle. So if it is paralyzed, it would result in foot drop. So common peroneal nerve is important in terms of the neck of the fibula.
But
Yes.
the common peroneal nerve is a branch of what nerve?
It is a branch of the sciatic nerve. So as we showed you in the popliteal fossa, at the upper end of the popliteal fossa, the sciatic nerve is going to divide into tibial and common peroneal nerves. Tibial will pass with the popliteal vessels, so it would be superficial with the popliteal vessels, while the common peroneal will pass along the biceps femoris, reach the neck of the fibula, where it is going to enter into the peroneus longus muscle and then divide into superficial and deep peroneal nerves. Deep peroneal nerve is going to supply all the muscles in the anterior compartment of the leg, and the major function of the anterior compartment of the leg is dorsiflexion. So if it is paralyzed because of the fractured neck of the fibula, you cannot do the dorsiflexion, so there would be foot drop. If we go down here, this is the interosseous membrane, which is lying between the medial border of fibula and the medial border of the tibia. We go down here, we would find the two malleoli. One is the medial malleolus, which is at the lower end of the tibia. This prolongation is called the medial malleolus. And then there is a prolongation from the fibula, which is called the lateral malleolus. And these malleoli are important because in between the two malleoli, you have the talus bone. So the ankle joint is formed between the lower end of the tibia and the talus. And because the two malleoli are coming from the side, they are basically giving stability to the ankle joint. So the malleoli are important because they are providing stability to the ankle joint. The lower end of the tibia here is going to articulate with the bone of the foot, which is called the talus, forming the ankle joint. So it is more like a hinge joint. So there would be dorsiflexion and plantar flexion. Dorsiflexion, plantar flexion, which is going to happen at the ankle joint. It is stabilized by this prolongation of the tibia, which is called the medial malleolus, and on the lateral side, the prolongation of the fibula, which is called the lateral malleolus. The inner aspect of this lateral malleolus, there is a malleolar fossa, and this malleolar fossa articulates with the talus. So there is a malleolar fossa here on the inner aspect of the lateral malleolus, which is going to articulate with the talus. Okay, now we look at some of the common type of injuries. As I said, tibia is one of the commonest bone which can get fractured. So if you have a compound open fracture, compound fractures are usually those fractures where you have multiple fragments. And open fracture, when we use the term of open fracture, it means that there is the bone is coming out of the skin. So it is fractured and it is coming out of the skin. That is a compound open fracture. So tibia and fibula are common areas where you can get compound open type of fractures. The fracture which you are seeing in the picture B is more of a stress fracture. And this stress fracture happens in people in tibia, especially in the upper third and lower third of the tibia, with people who start to do sternus exercises without acclimatizing. So if you are not acclimatized to sternus exercise and you start to do long distance running, you might have a stress fracture in the tibia. And this type of stress fracture which you are seeing here is called a march fracture of the tibia. So march fracture of the tibia happens because of the stress. If you start to do extensive exercise without acclimatizing, it can lead to stress fractures in the tibia. Yes?
Is it the same thing as a shin splint?
No, this is not shin splint, but this is a stress fracture. This is a fracture of the bone, and it happens because of sternus exercise without acclimatizing. Long distance running without acclimatizing to it. You start with 2 kilometers or 3 kilometers and then do a long distance. You start to run 40, 30 kilometers without acclimatizing your body to it. It can result in stress fracture of the tibia, which is called the march fracture. The other type of fractures which you can see in tibia are diagonal fractures and transverse boot top fractures. So these diagonal fractures happen in skiing, for example, when you are, you skid and turn. So that can result in a diagonal type of fracture. The other type of fracture which can happen skiing is the boot top type of fracture. This boot top type of fracture happens because the skiing boot is quite rigid here. So it is tied to your leg here. And if you fall over it, there would be a transverse fracture of tibia and fibula. If I'm doing skiing and I have a fall over it, because the boot is so rigid, my leg will stay there and I would fall over it. And as I would fall over it, there would be a transverse type of fracture of the tibia. It's called a boot fracture. Okay? So it can happen with any type of injury where you have the boots which are rigid and then you fall over the boots. So that will result in a boot type of fracture. And it can happen also in skiing. You can see it here. This skier is skiing and he's falling over the boot. So as he's going to fall over the boot, there would be a transverse type of fracture of the lower part of the tibia and fibula. It's a transverse fracture, rather than a rotational injury which will result in a diagonal fracture. So this is a boot type of injury. both type of fracture which can happen in skiing.
Doctor,
Yes,
notch fracture, only the tibia will be fractured.
yes, and it's a stress fracture of the tibia, so it's not a complete fracture. It would be a chip of the bone you would see slightly fractured here. You see this slightly chipped.
And what's exactly the relationship between warming up and
Yeah, because if you acclimatize yourself, then the bone strength will be according to the type of the workout you are going to do. If you are putting too much pressure on the bones which are weight bearing, and you have not acclimatized your body according to it, it will not be able to take the weight. For example, people start to do, they start to bowl heavily, and then they have stress fractures on their vertebrae because they are twisting their bodies and there's too much pressure on their vertebrae and their body is not acclimatized to it. The muscles are not developed. Okay, so if there is the body is not acclimatized and you have, you start to do long distance running and other things, and you can end up with march fractures, which are basically stress fractures of tibia. Okay, next we are going to look at the malleolar fractures. You can also have fractures of medial and lateral malleolus together, like in eversion type of injuries. If your limb gets everted, when you are basically trying to walk and you suddenly have eversion of the foot, it can result in fracture of both medial and lateral malleolus. And inversion injury in which your foot gets inverted, that results in more of a lateral malleolar injury. So you can have lateral malleolar fractures in inversion injuries, and you can have both the malleolar fractures if you have eversion type of injuries.
You
Yes.
mean a step in your leg like this?
Yeah, in stepping type of injury is inversion injury. It will result in lateral malleolar fracture. Eversion type of injury would result in both malleoli getting fractured. So in eversion injuries, you may have both medial and lateral malleolus fractured. In inversion injuries, you would have the lateral malleolus.
I had
which
this
can
twice.
Yeah.
Within 2 months.
You need to be careful because these ligaments do not, heal so well. Okay, now we are looking at some of the cutaneous nerve supply, and this is the front of the leg, and this is the back of the leg. So in the front of the leg, if you see, the medial side is supplied by the saphenous nerve, which is a branch of the femoral nerve. The lateral upper 2/3 of the leg is supplied by the lateral cutaneous nerve of the calf and lateral sural cutaneous nerve. These are the branches of the common fibular nerve. Lateral cutaneous nerve of the thigh and the sural communicating branch, they are basically supplying the lateral upper 2/3 of the leg. Lower 1/3 of the leg, which you see in yellow, and the dorsum of the foot is supplied by superficial fibular nerve or superficial peroneal nerve, except the cleft between the first toe and the second toe. So the web between the first and the second toe is supplied by the deep peroneal nerve. The rest of the lower 1/3 and the dorsum of the foot is supplied by superficial peroneal. Above that, the lateral 2/3 is of the upper part of the leg is supplied by the lateral cutaneous nerve of calf and the sural communicating. The medial part of the anterior part of the leg is supplied by the saphenous nerve. So these are the cutaneous supply on the anterior aspect. If you look at the cutaneous supply at the posterior aspect, the lateral side, again it is supplied by the lateral sural cutaneous, which is a branch from the common fibular. Medial side mainly by the saphenous. The posterior aspect is supplied by the sural cutaneous nerve, and this sural cutaneous nerve is going to supply most of the posterior aspect of the back of the leg. As we go down on the plantar aspect of the foot, medial 2/3 is supplied by medial plantar nerve, lateral 1/3 is supplied by the lateral parental nerve, which are branches of the tibial nerve. So these are the cutaneous supply. You can read this if you want to, but these details are not required. The important things I have already talked about in terms of the distribution of the cutaneous nerves. Okay, can somebody read this question for me? Somebody at the back, yes. You.
A 35-year-old professional baseball player is hit on the side of his right leg with a bat. He suffers a fracture of the proximal fibula, a nerve that runs near the fracture is injured. What would you expect to see on a physical examination?
Foot drop. Okay. So one thing is that you can see that this fibula is fractured here. So this is the neck of fibula. So foot drop is one thing, which is the dorsiflexion of the foot. The other thing which is important, because this is a common peroneal nerve, so it gives two branches. One is the deep peroneal, and then one is the superficial peroneal. And as you saw in the cutaneous distribution, that lower 1/3 of the lateral aspect of the anterior lateral aspect of the leg and the dorsum of the foot is supplied by superficial peroneal. So that you would lose sensation over the lower part of the anterior aspect of the leg and the dorsum of the foot. Yes.
We also lose the actual eversion.
Yes.
As a solution.
Yes, you would lose the eversion also, because superficial peroneal is going to supply the peroneus longus and brevis, which are the lateral compartment muscles, and they are the everters of the foot. So if you see here, you would have, do you have weakness of plantar flexion? No. Weakness of ankle eversion? Yes. Weakness of dorsiflexion? Yes. Numbness over the dorsum of the foot? Yes. Numbness in the space between the first two toes? Yes. Because deep peroneal nerve. Because we are talking about common peroneal. This is supplied by deep peroneal. This is supplied by superficial peroneal. Numbness of the sole of the foot? No, because it is supplied by the tibial nerve. So out of these, B, C, D, and E are all correct answers. Yes.
So wouldn't you have complete loss of dorsiflexion? Not weakness?
No, we would have weakness, because we still have, a little bit of function might be there. Usually, you are right that we should have, complete loss of dorsiflexion because nerve. Yeah. Okay. Let's go to the objectives again. Okay, so the next bit of objectives which we are going to talk about is that we are going to talk about the compartments of the leg. We will describe the nerve supply, origin, insertion, and actions of the muscles of the leg, and we would describe the blood supply of the leg. These are the major objectives which we would deal with in this section. So if we start with the compartments of the leg, we have the skin on the outer aspect as in the thigh. Then you have the superficial fascia. Then you have the deep fascia of the leg. And the deep fascia of the leg is quite thick. And then you have the two bones, the tibia and the fibula. This area of the tibia is subcutaneous, so this is the subcutaneous area of the tibia. It's more of a triangular bone if you see. So it has an anterior medial surface, anterior lateral surface, and this is the posterior surface. This is the medial border of the tibia and the interosseous border of the tibia and the medial border of the fibula. So this is the interosseous membrane. This is the anterior and the posterior border of fibula. So you have two intramuscular septums, one attached to the anterior border, the other attached to the posterior border of the fibula. And this actually divides the leg into three compartments. You have an anterior compartment of the leg, which is in front of the interosseous membrane and in front of the anterior intermuscular septum. This compartment is mainly dorsiflexor, and it has one inverter of the foot. So it has mainly dorsiflexors and one inverter of the foot. The nerve supply here is the deep fibular nerve. The muscles which you see in the anterior compartment are extensor muscles, because in front of the ankle joint, whatever is going to go is going to cause extension of the ankle joint. But extension can be called as dorsiflexion. The muscles here, as I said, they should be extensors, so there would be an extensor going to the big thumb, big toe, so that is called the extensor hallucis longus. The one going to the digits is called extensor digitorum longus, and then you have tibialis anterior, which is the inverter of the foot. There's also a small muscle in this compartment which is called the peroneus tertius or famularis tertius. This muscle is an inverter of the foot and also the dorsiflexor of the ankle. The nerve supply here is the deep peroneal nerve or deep fibular nerve, which is a branch of common fibular nerve. Now if we go to the compartment which is the lateral compartment, it is present between the anterior intermuscular septum and the posterior intermuscular septum. The main function of this compartment of the leg, which is the lateral compartment, is eversion. There are two muscles here, peroneus longus and peroneus brevis, or fibularis longus or fibularis brevis muscle. And then we come to the posterior compartment, which lies behind the posterior intermuscular septum and the posterior aspect of the tibia and the fibula. And this compartment is further divided by a transverse septum into superficial and deep compartments. The superficial has 3 muscles and deep has 3 muscles, or you can say 4 muscles. 3 muscles in the superficial compartment include gastrocnemius, plantaris, and soleus. These 3 muscles are gastrocnemius, plantaris, and soleus are powerful plantar flexor of the ankle. So they have one function, which is the plantar flexion of the ankle joint. The 3 deep muscles or the 4 deep muscles include popliteus, flexor hallucis, flexor hallucis longus, flexor digitorum longus, and tibialis posterior. And like tibialis anterior, tibialis posterior is also an inverter of the foot. The rest of them are plantar flexors of the ankle joint, and they also do, like the flexor hallucis is going to go to the big toe, so it is going to do the plantar flexion of the big toe, while the flexor digitorum longus is going to go to the lateral 4 toes, so it is also important in flexing the lateral 4 toes. Okay? So if we look at these, the major nerve supply of the lateral compartment is the superficial peroneal nerve, and the major nerve supply of the posterior compartment is the tibial nerve. So the lateral compartment are everters. Their muscles here are peroneus longus and peroneus brevis. The posterior compartment of the leg are plantar flexors and inverters. There are 2 set of muscles, the superficial and the deep. The superficial are gastrocnemius, soleus, and plantaris. The deep are flexor hallucis longus, flexor digitorum longus, and tibialis posterior. Tibialis posterior, like tibialis anterior, is an inverter of the foot. The nerve supply of the posterior compartment is the tibial nerve. The nerve supply of the lateral compartment is superficial peroneal nerve, while the nerve supply of the anterior compartment is deep peroneal nerve. We get a 5-minute break, and then you will start with the next part. Okay, so we have done the compartments of the leg. Now we are going to do the individual compartments, and we'll start with the anterior compartment of the leg. The anterior compartment of the leg mainly consists of muscles which are dorsiflexors and inverters. So mainly the extensor hallucis longus and extensor digitorum longus are dorsiflexors, and tibialis anterior is the inverter. Yes.
So when we increase the angle of the joint, that's a flexion. So
Yes.
why in the angle when we increase the angle is called extension?
Yeah, you are basically, you are doing what?
Why dorsiflexion, we call it an extension. But we are decreasing the angle like this.
Yeah, that's why the term dorsiflexion comes in, but you know that in the front of the lower limbs you have extensors there, and at the back of the lower limb you have the flexor. So anything which is going to go in front of the joint is an extensor. Anything which is going at the back of the joint is a flexor in the lower limb. So the summary here is that the muscles which are present in the anterior compartment of the leg are dorsiflexors and inverters. The inverter is basically the tibialis posterior. The dorsiflexors are extensor hallucis longus and extensor digitorum longus. Dorsiflexion happens at the ankle joint. So dorsiflexion is basically happening at the ankle joint, while the inversion and eversion of the foot is basically happening at the subtalar joint. That is the joint between the talus bone and the calcaneum. So there is a joint between the tibia and the talus bone. That is the ankle joint. So the action there is happening is dorsiflexion and plantar flexion. Below the talus, between the talus and calcaneum, the joint is called the subtalar joint, and in this subtalar joint the inversion and eversion of the foot is happening. So inversion and eversion of the foot, these movements do not happen at the ankle joint, they happen at the subtalar joint. Okay. Next, the nerve supply of the anterior compartment of the leg is the deep peroneal nerve, as we said. This compartment contains three so-called honest muscles, and we call them honest muscles because they do not change their relationship. So we will see the three dishonest muscles in the leg also, but the three honest muscles in the leg are in the anterior compartment, that are tibialis anterior, extensor hallucis longus and extensor digitorum longus, and they will keep their orientation as they pass through the ankle joint. So the three muscles which we said are tibialis anterior, extensor hallucis longus, and the third one is the extensor digitorum longus. If we look further into the anterior compartment of the leg, we'll see that in the anterior compartment, this common peroneal nerve, which is lying near the neck of the fibula, it is going to enter into the peroneus longus muscle and then divide into deep peroneal nerve and the superficial peroneal nerve. The deep peroneal nerve, after piercing the peroneus longus muscle, will come into the anterior compartment of the leg, supply all the three muscles in the anterior compartment of the leg, and will run along with the artery which is called the anterior tibial artery. So you would see that the deep peroneal nerve is running with the anterior tibial artery, which as it passes through the ankle joint, this anterior tibial artery will become the dorsalis pedis artery, and this dorsalis pedis artery is going to give medial, the anterior tibial at the ankle joint is going to give medial malleolar and the lateral malleolar branches, or the lateral tarsal arteries, and then it will become the dorsalis pedis, and the dorsalis pedis itself is going to give rise to the arcuate artery, which will give the digital branches, and dorsalis pedis will dip down from the space between the first and the second toe and will join the plantar arch on the plantar aspect of the foot.
Can you please repeat that?
Yeah. So what we are saying here is that this anterior tibial artery is going to continue below the ankle joint as the dorsalis pedis artery. Dorsalis pedis artery is going to give rise to the arcuate artery, which is going to give rise to the dorsal digital arteries, and itself the dorsalis pedis between the first and the second metatarsal is going to dip down into the plantar aspect of the foot, where it is going to join the plantar arch. There is a plantar arch on the plantar aspect of the foot where it is going to join this dorsalis pedis artery. Okay. If we look at the muscles here, put up the muscles. So the first muscle here is the tibialis anterior muscle, and this tibialis anterior muscle arises from the anterior lateral aspect of the tibia. So anterior medial aspect of the tibia is subcutaneous. The anterior lateral aspect of the tibia is going to give rise to this muscle, which is the tibialis anterior. It goes down below the extensor retinaculum to get attached to the medial cuneiform bone. So if you look at these bones here, this is the talus, and then in front of the talus you can see the navicular bone. On the lateral side, this is the cuboid bone, and then you have the three cuneiforms: the medial cuneiform, intermediate cuneiform, and the lateral cuneiform. So this tibialis anterior is going to go and get inserted on the medial cuneiform and to the base of the first metatarsal bone. As it is going to contract, the tibialis anterior is going to, as it's attached to the medial aspect, is going to invert the foot. And it is also the dorsiflexor at the ankle joint, because it is passing in front of the ankle joint also. The nerve supply of tibialis anterior is deep peroneal nerve, which is going to supply the anterior compartment muscles. The second muscle which you are seeing here, which is arising from the medial, anterior medial, or the medial aspect of the fibula. Can you see this one? The brown muscle. It is arising from the middle part of the medial surface of the shaft of the fibula and the adjoining interosseous membrane, and then it passes below the extensor retinaculum, goes to the distal phalanx of the big toe. It is called the extensor hallucis muscle. Again, it is the dorsiflexor at the ankle joint. It also causes dorsiflexion of the big toe. The nerve supply of the extensor hallucis longus is deep peroneal nerve. Then we have the extensor digitorum longus. We go back a little bit. This is the extensor digitorum longus, which is the lateral most muscle here. So it is arising from the anterior aspect of the fibula. The uppermost part is also arising from the lateral tibial condyle. So it is arising from the lateral tibial condyle, from the head of the fibula, and from the upper part of the anterior surface of the fibula. And it is going to pass below the extensor retinaculum, the superior and the inferior extensor retinaculum, divide into 4 tendons for the lateral 4 toes. When these 4 tendons are going to reach the phalanges, what would happen is that they would divide into 3 slips. The 2 slips of each tendon are going to get attached to the side of the middle phalanx, while the middle of the slip is going to go to the base of the distal phalanx. So you have 4 tendons of the extensor digitorum longus, which each of them, when they reach the phalanges, they are going to divide into 3 slips. 2 slips are going to get attached to the sides of the middle phalanx, and one of the slip, the middle the slip, is going to go and get attached to the base of the distal phalanx. The action of the extensor digitorum longus is to dorsiflex the ankle and the dorsiflex the lateral 4 toes. Again, the nerve supply is deep fibular nerve, or the deep peroneal nerve. The muscle which is not shown here is the peroneus tertius, which arises from the lower part of the anterior surface of the shaft of the fibula and gets attached to the base of the 5th metatarsal bone, and that is called the peroneus tertius muscle. Again, it is a dorsiflexor of the ankle, and it also does eversion of the foot. The nerve supply is deep fibular nerve. So these are the 3 muscles, and you can see that 3 of them are maintaining their orientation at the ankle. So the medial most is the tibialis anterior, then you have the extensor hallucis, then you have the extensor digitorum, and this orientation remains the same at the ankle joint. So that's why they are called honest muscles. And the nerves, if you see the vascular bundle is lying between tibialis anterior and the extensor hallucis, and then between extensor hallucis and extensor digitorum as they reach the ankle joint. So this remains the same, but the fascia over the anterior compartment is quite tight. So there is no space in the anterior compartment of the leg. So if you have any swelling inside or any edema inside this space, this will lead to compression of the nerves and compression of the arteries. So it is going to result in compartment syndrome because this space is quite tight. So sometimes even people who suddenly start to do exercise and start running, they start to have pain on the tibialis anterior or the anterior part of the shin, which is called the shin splints. And these shin splints are happening because what is happening is that tibialis anterior swells up, and as it is going to swell up, there is no space here. It is going to compress the nerves and the vessels, which will result in pain on the anterior aspect of the leg. So that is what is called the shin splint, and it happens in people who suddenly start to do exercise after a long period of sedentary lifestyle. They start to do running or doing what. So that result in increase in the size of the muscle, which compresses the nerves and vessels, and as a result you have pain on the anterior aspect of the leg, and that is called the shin splint. Yes?
What do you mean the orientation of these muscles? What do you mean by orientation?
Yeah, so tibialis anterior will remain at the ankle on the most medial aspect, then you have the extensor hallucis, then you have the extensor digitorum. So the orientation, the way from medial to lateral these tendons remains the same from the top to bottom. So they are not changing their orientation. Now no tendon is crossing each other at the ankle. Okay? So we have talked about the compartment syndrome. So any fluid buildup because of severe burn or bleeding or sudden hypertrophy of the leg muscles may lead to compartment syndrome in the anterior compartment because there is no space there. So due to tight and tough fascia, which packs the leg muscles into tight compartment with little or no room for expansion. Any fluid accumulation, bleeding, etc. within this compartment lead to rapid increase in pressure, which may result in muscle ischemia and nerve compression. And that's why you might have pain in the anterior compartment because of the hypertrophy of the muscle or fluid accumulation or anything. That can lead to compartment syndrome in the anterior compartment. Okay, then we have the lateral compartment, and we said that the lateral compartment, mainly these are everters, and they evert the foot at the subtalar joint. The two muscles here are peroneus longus and peroneus brevis. The nerve supply is superficial peroneal nerve. Mainly the peroneal artery is going to supply here, which is a branch of the posterior tibial, but it is not present inside the lateral compartment. It is not the content of the lateral compartment of the leg. It supplies that area, but it is not the content of that compartment or the lateral compartment of the leg. We have talked about these two muscles. If we look at these two muscles, we will see that these two muscles are going to originate from the lateral aspect of the fibula. So the first one which you are seeing is arising from the head of the fibula and the upper 3/4 of the lateral surface of the fibula, and then it is going to pass over the trochlea of the calcaneum. It is going to groove the lateral malleolus posteriorly, and then it is going to pass above the calcaneal trochlea, and then as it passes below the foot, it is going to go all the way to the medial aspect, reaching to the base of the first metatarsal and the medial cuneiform bone. So it is going to travel all the way down on the base of the foot to the medial aspect of the foot and get attached to the base of the first metatarsal and the medial cuneiform. So you can imagine that it is going all the way down. So if it is going to pull, it is going to evert the foot. So peroneus longus is going to start from the head of the fibula, upper 3/4 of the lateral surface of the fibula, grooves the posterior aspect of the the lateral malleolus, then passes above the calcaneal trochlea, then goes under the foot all the way to the medial side where it is attached to the medial cuneiform and to the base of the first metatarsal bone. The action is eversion of the foot. Then the second muscle here is the peroneus brevis, and this peroneus brevis muscle is going to arise from the lower 3/4 of the lateral surface of the shaft of the fibula. It is going to pass below below the trochlea of the calcaneum, and it is inserted on the base of the fifth metatarsal bone. So it is attached to the tuberosity of the fifth metatarsal bone. The action is eversion of the foot. Nerve supply of these muscles are superficial peroneal, fibular or peroneal nerve. Yes. Yeah, so there is an elevation on the side of the calcaneum. So this is the calcaneum. There is an elevation here. So the peroneus brevis muscle passes above the trochlea, and peroneus longus passes below the trochlea. So you have an elevation like this on the side of the calcaneum. So the brevis muscle is going to pass above it, longus muscle is passing below it. Okay, and there are two separate compartments because there is a peroneal retinaculum also. So this is in a separate compartment, this is in the separate compartment with their own synovial sheets. Okay, so you have a peroneal trochlea on this side here. So peroneus brevis is passing above it, peroneus longus is passing below it, and there is a retinaculum, which is the peroneal retinaculum, which you can see it here. See, this is the superior peroneal retinaculum and this is the inferior peroneal retinaculum. So this is attached to the trochlea. There is an upper compartment, there is a lower compartment. From the upper compartment you have the peroneus brevis. From the lower compartment you have the peroneus longus. Okay. We have already talked about the common peroneal nerve, and it may be injured around the neck of the fibula, which can result in foot drop, and we know why it can result in foot drop. Okay, now we come to the posterior compartment, and the posterior compartment muscles include plantar flexors and inverters. We said that there are three superficial muscles in the posterior compartment: gastrocnemius, plantaris, and soleus, and three deep muscles which include flexor hallucis longus, flexor digitorum longus, tibialis posterior, which is an inverter of the foot also, and sometimes popliteus also taken as the one of the deep muscles of the posterior compartment. The nerve supply is by the tibial nerve. The blood supply is by the posterior tibial artery. And if we look at the superficial layer, we have already talked about that these are the three muscles in the superficial layer. And then deep layer, you have flexor hallucis longus, flexor digitorum longus, and tibialis posterior. These are the three so-called dishonest muscles, the flexor hallucis, digitorum, and tibialis posterior, because they would change their positions with respect to what they are in the leg and how they cross the ankle joint, and then how they are crossing in the foot. So flexor digitorum and flexor hallucis will change their position in the foot, while tibialis posterior and the flexor hallucis are going to flexor digitorum are going to change their position as they pass through the ankle joint. Yeah, but fibularis longus, these are the two muscles, which are there. There are not many muscles. There are only two muscles in the lateral compartment. So okay. So the first set of muscle which we are going to look at is the gastrocnemius muscle. is going to arise from the medial and lateral condyle of the femur, and it is going to get inserted on it is going to form an epineurosis with the soleus and the plantaris muscle, and this epineurosis is going to form a tendon which is called the tendocalcaneum, and it is attached, this tendocalcaneum is attached to the tuberosity of the calcaneum. Now, the muscle fibers here in the gastrocnemius, the medial and the lateral head of the gastrocnemius, are fast contracting fibers. So it is important in a rapid push off. So when you are pushing off your feet from the ground and you want to do a rapid push off, like you are jumping in a basketball, or you are running, or you are tripping, or you are starting your movement suddenly, the rapid phase of your movement is basically, rapid push off is the action of, or rapid plantar flexion is the action of the gastrocnemius. Okay, while the other muscle which you see, which is going to be inserted into the tendocalcaneum, is the soleus muscle, and that is a slow, strong plantar flexor. So gastrocnemius is a fast acting muscle, while the soleus is a slow acting muscle. So in a sustained movement, the soleus is the one which is going to act. Okay, so the second muscle which you are going to see is the soleus muscle, and this soleus muscle, if we are going to see, is going to arise from the head of the fibula. It is arising from the soleal line and the posterior aspect of the shaft of the fibula and the tibia, and this is going to be inserted into the tendocalcaneum also. So this muscle is a slow acting muscle, but it is important in doing plantar flexion and sustained plantar flexion. As you are walking, you are using your soleus to contract and to move, to do plantar flexion. But if you want to do a rapid push off, that is where the gastrocnemius is important. Now soleus also has a rich plexus of veins inside it. So a rich plexus of venous plexus. From the superficial veins, the perforating veins are going to form a rich plexus of veins within the substance of soleus, and then the soleus is going to communicate with the deep veins, which are passing all below the soleal arch. So below the soleal arch, you would see the posterior tibial artery. Along with it would be the deep veins, the posterior tibial veins which are passing, and there is a plexus of veins within the soleus muscle, which are the perforating veins, which are going to pass through into the deep veins. Now when the soleus is going to contract, it is going to push the blood, from the veins up, because it's outside the deep veins. So when it is going to contract, it is going to push the deep veins, push the blood up. And similarly, it is going to squeeze the plexus of veins which is inside to push the blood into the deep veins. As this is going to happen, it is going to produce a suction effect on the superficial veins, and this will allow the movement of the blood from the superficial veins into the deep veins. Okay, so that's why soleus is sometimes also called as the peripheral heart, because it is pumping the blood from the lower extremities upward. The third muscle here in the three superficial muscles is called the plantaris muscle, and the plantaris muscle is going to arise from the lateral supracondylar line, and it is getting attached to the tendocalcaneum tendon, and through the tendocalcaneum tendon it is attached to the calcaneum. Again, the action is plantar flexion. But the plantaris muscle doesn't have real action, because you can see it is a very thin muscle, and in 15 to 20% of the people it might be absent also. But in people where the plantaris muscle is there, and if its tendon ruptures for some reason, what would happen is that there would be an excruciating pain on the back of the calf, disproportionate to the size of the tendon. So the size of the tendon is so small, but it gets ruptured, you would have excruciating pain on the back of the leg. So this happens in some people, that if there is a rupture of the plantaris tendon, there could be an excruciating pain on the back of the leg. You can also have a rupture of the tendocalcanean tendon. And if this ruptures, then you would have an audible snap. That means you would hear the rupture. There would be an audible snap and there would be dorsiflexion of the foot. So there would be pain, an audible snap because of the rupture of the tendocalcaneum, and there would be dorsiflexion of the foot. Which people would get rupture of the tendocalcaneum? Usually people who do, when you are performing a rapid movement, like, you're jumping up and putting the basketball into the basket, or you are doing a high jump, and then or a long jump where you are using your gastrocnemius and suddenly the tendon ruptures. So rupture of the gastrocnemius tendon or the tendocalcaneum happens in rapid push-off movements, like jumping up to put up the basket, doing a long jump, or start of a run. You can have rupture of the tendocalcaneum. Yeah, the tendocalcaneum is the Achilles tendon. So calcanean tendon and plantaris tendon in particular commonly rupture in sporting activities, especially those involving sudden stops and starts and jumps, example basketball, squash, high jumping. When the plantaris tendon ruptures, the pain can be excruciating and out of proportion to its small size. The long slender plantaris tendon is often used for tendon repairs also. So if you have tendon ruptures in the upper limb, you can harvest the plantaris tendon and use it for tendon repairs in the upper limb. Yeah, grafting. Okay, deep layer. The three dishonest muscles. The first one which you are seeing, the medial most, which is arising from the medial part of the posterior surface of the tibia below the soleal line, is the flexor digitorum longus. It passes below the flexor retinaculum and divides into four tendons which are going to the lateral four digits. Now, so the muscle which is the tibialis posterior. Now, tibialis posterior lies lateral to the flexor digitorum longus. So it is arising from the lateral half of the posterior surface of the shaft of the tibia and also from the interosseous membrane. But when it reaches the ankle joint behind the medial malleolus, it crosses the flexor digitorum. So it is going to lie the medial most structure at the ankle joint, behind the ankle joint. So tibialis posterior would be medial to the flexor digitorum. So they are now changing the position. The flexor digitorum was mainly medial in the leg, and as it passes below behind the medial malleolus, it has become lateral to the tibialis posterior muscle. This tibialis posterior muscle is inserted to the navicular bone. It is attached to the medial cuneiform, and it is also attached to the second, third, and fourth metatarsal bones. So it is attached to the cuneiforms, it is attached to the navicular bone and to the metatarsal bone. But you can see that it arises from the lateral half of the posterior surface of the shaft of the tibia and interosseous membrane, and near the ankle it crosses the flexor digitorum, becomes medial to the flexor digitorum longus. Now look at the last muscle here, which is the flexor hallucis longus. It arises from the posterior surface of the shaft of the fibula. So this is the most lateral muscle, and see, as it is going to pass the flexor retinaculum at the ankle joint, it is still lateral most. So the most medial is tibialis anterior, then you have flexor digitorum, and then you have flexor hallucis. But in the foot, this flexor hallucis is going to cross the flexor digitorum to reach the base of the big toe. Yeah, the phalanx of the big toe. So it is going to cross the flexor digitorum in the foot to come on the medial side, and then it is going to get attached to the base of the distal phalanx of the big toe. The function of all three muscles is plantar flexion, but tibialis posterior is going to also cause the inversion of the foot. And inversion of the foot is also done by tibialis anterior, which is the muscle of the anterior compartment. Okay. The arteries which you are going to see in the posterior compartment, the tibial artery, the posterior tibial artery, which is the continuation from the popliteal artery. The popliteal artery is giving two arteries here. One is the posterior tibial and the other one is the anterior tibial, which is passing through the interosseous membrane to the anterior compartment of the leg. The posterior tibial itself is going to give a peroneal branch here, which is going to supply the lateral aspect of the posterior part of the leg, and it is also going to give branches to the lateral compartment of the leg. Posterior tibial itself is going to pass below the flexor retinaculum, and then it is going to divide into the medial and the lateral plantar arteries. So it is going to divide itself into medial and lateral plantar arteries. You can see the flexor retinaculum here, which is lying between the medial malleolus and the calcaneum. And if you look at the contents here, the relationship from medial aspect of the ankle from anterior to posterior is tibialis anterior, flexor digitorum longus, then you have the vessels, the posterior tibial artery and vein, and then you have the tibial nerve, then you have the flexor hallucis longus, which is the lateral most thing in the under the flexor retinaculum. So under the flexor retinaculum, if you are going from medial to lateral, you have the most medial structure is tibialis posterior. This is wrong. Tibialis posterior, flexor digitorum longus, posterior tibial artery and vein, tibial nerve, flexor hallucis longus. These are the structures from medial to lateral under the flexor retinaculum. So you can remember an acronym which is Tom, Dick and very nervous. Heavy. So Tom is for tibialis anterior, Dick is for the flexor digitorum longus, and is for the posterior tibial artery and vein, and then nervous is for the tibial nerve, and Harry for the flexor hallucis. And if you see the actions, these are the actions of the muscles which we have talked about. So inversion, eversion, these are the inverters and these are the everters. The muscles in front are dorsiflexors, the muscles behind are plantar flexors. We have talked about the ruptured calcanean tendon. We haven't talked about the gastrocnemius strain, so it's a painful acute injury to the medial head of the gastrocnemius. It can happen in overstretching and dorsiflexion at the same time. So if you are overstretching the knee and then at the same time dorsiflexing, it can result in the injury to the medial head of the gastrocnemius. This is called the tennis leg. You can also have calcaneal bursitis. There is a bursa between the Achilles tendon and the calcaneum. So in sports where you have repeated movements like jumps or basketball or in sports where you have rapid movements, there could be friction between the Achilles tendon and the bursa, and as a result you can have calcanean bursitis. And finally we are looking at some of the arteries. Again, you can see this is the popliteal artery, which is dividing into the superior genicular and superior medial genicular and superior lateral genicular, and then you can see medial inferior and medial lateral genicular, and then you can see the popliteal artery below the posterior border of the popliteus muscle is going to continue as it is going to divide into the posterior tibial and the anterior tibial. The posterior tibial is going to go behind the soleal arch and will supply the posterior aspect of the leg. the anterior tibial is going to go to the anterior aspect of the leg and will supply the anterior aspect of the leg. If you follow the anterior tibial, it is going to go below the ankle joint. It will become the dorsalis pedis artery, and this dorsalis pedis artery is going to give an arcuate artery, and itself it is going to dip down from the space between the first and the second metatarsal to continue with the plantar arch, while the posterior tibial on the back of the leg is going to give the peroneal artery or the fibular artery. Itself it is going to go straight down, and at the ankle joint it is going to divide into medial and the lateral plantar arteries, which are going to supply the medial and lateral aspect of the foot. Yes.
We are meant to stand a lot, right?
Yes.
Then how come the anterior tibial artery goes back on the sole of the foot? It couldn't be blocked by standing a lot?
Standing anterior tibial artery, how it would be blocked?
Because he just said that it will pass under the...
No, so there is a lot of pad of fat in the foot. So the arteries cannot be blocked because of your standing, because there is a lot of pad of fat in the foot which is going to give protect the, and there are muscles also. So we will talk about the muscles in the foot also, and we will see how much pad of fat is there, which is going to protect the neurovascular bundle. So neurovascular bundle is not superficial in the foot. It is lying below the muscles and below the pad of fat. So it's not basically compressed by your weight. And your weight is not transmitting in the middle part of the foot. Your weight is transmitted through the heel and the front part. You have an arch of the foot like this. So your weight is not transmitted in the center. Your weight is transmitted in the front and at the heel. And that's why the arches of the foot are important, and we are going to talk about them. The pulses which you usually take are behind the medial malleolus. You are basically feeling the posterior tibial artery, and in front, midway between the two malleoli, you are feeling the dorsalis pedis artery. These are the two major arteries which you basically feel behind the medial malleolus and the calcaneum. You are feeling the posterior tibial artery, and in front between the two malleoli you are basically feeling the dorsalis pedis artery. So dorsalis pedis artery between the two malleoli in front, and behind the medial malleolus, between the medial malleolus and the calcaneum, you are feeling the posterior tibial artery. So these are the places where you are going to feel the pulse of dorsalis pedis and the posterior tibial artery. Again, this angiogram is giving you some of the major arteries. So you can actually see the popliteal artery here. You can make out the posterior tibial artery and the anterior tibial artery. You can also make out the posterior tibial artery here, and this becomes the dorsalis pedis here. So only the main arteries you should be able to identify. We are not going to ask you some arteries which are very small. Okay, a question for you. Somebody from the back. Yes, you at the end. Yeah. Can you read the question for us? Gangrenous left great toe. An angiogram is taken off. So an angiogram is what? What is an angiogram?
When you put the dye inside the artery,
Visible. And then you take the radiograph. So you see these arteries here. This is a normal person. You put up the dye and you can see all the arteries here. What you are seeing here?
no, the arteries are not that visible.
Left leg. There is a cut between the right leg.
So you can see a lot of arteries are not seen here, which you can see here, because the dye is not there. So that means that the blood is not going into these arteries. So these arteries are blocked. And this patient is a diabetic and heavy smoker. So in heavy smokers and diabetes, you can have a disease which is widespread arterial disease. So you can have, this patient doesn't has thrombosis of the vein. He is suffering from a diffuse arterial disease.
And that means that there is a number of arteries which are blocked because of atherosclerosis, and atherosclerosis happens in diabetes as well as in smokers. Atherosclerosis is narrowing of these blood vessels. It happens because of fat accumulation or accumulation of structures within the arterial blood wall. This will result in narrowing of blood vessels, and as a result you have a diffuse arterial disease here. Okay, so the last thing which we are going to talk about is this peripheral, the calf as a peripheral heart. So you know that these vena comittantes are along with the arteries, and they are enclosed by a fascia. So when the arteries, and outside these arteries there are muscles, and the muscles are also covered by fascia, and outside this fascia is the superficial veins, and these superficial veins are communicating with these veins by perforating veins, and all of these veins have valves which will allow only the blood to move from superficial to deep and from deep to up. Okay, so this is how the blood is moving. Now look at it, what happens in the normal situation. So you have your blood vessels contracting, and as the blood vessels are contracting, they are increasing the pressure over the deep veins. Okay, furthermore your muscles are contracting. So as the muscles are going to contract, they are going to further compress the deep veins. So the arteries are compressing the deep veins, and you have compression by the muscles. So this will push the blood up. So this is because it cannot go this way because you have the valves. So it can only go this way up. So that's how your calf muscles are acting as peripheral heart, and they are pushing the blood up. So this is the only way where the blood can go. It can go up through the deep veins. Okay. Next, if you have, normally you have this type of movement. The blood is moving from the superficial veins. Because of this action of the muscles, it becomes a suction vacuum which will pull the blood from the superficial veins into the deep veins. So there is a siphoning action of the contraction of the muscles which will pull the blood from the superficial veins into deep veins. But if you have your valves, if you have your valves become incompetent, then the blood will move from the high pressure veins to the superficial veins, leading to varicose veins. Thank you.